Good afternoon, everyone. Thanks for joining. DataGen is excited to present to you at your State Association and System request the Medicare Fiscal Year 2021 Inpatient Final Rule, and also the analysis, which hopefully you received your hospital-specific analysis at this point. Today's webinar is being recorded and will be shared with you with the PDF of today's slides tomorrow. DataGen provides these analyses to state associations and health systems throughout the country. And today, Jacob Orsini and Lauren Davis will be presenting the analysis and the rule to you. The detail of the final rule, you have a lot more in the accompanying brief that you also received. And feel free, if needed, to ask any questions using the chat feature on your screen. And with that, I'll turn it over to Jacob Orsini to talk through the final rule. Jacob, it's all yours.
Thank you, Susan, and good afternoon, everyone. So I'm just going to go over a quick overview of what you're going to be seeing as we go through this presentation. We're going to be going over some of the basic rate updates, some DSH updates. Then we'll be going and taking a look at the wage index changes, primarily the CBSA changes and impacts due to the new OMB delineations that CMS finalized in the final rule. And we'll also then have Lauren go over some of the quality programs that we do analysis on. One thing that you should, many of you have probably seen, is that the rule came out a little bit later than usual, right at the beginning of September. This was due to a delay because of the COVID pandemic. So we're going to start in on rate updates. So the final market basket base was a 2.4% increase, which is about an increase of about $2.5 billion. And normally this would be reduced by the Affordable Care Act multi-factor productivity adjustment. However, due to June 2020 economic data, which was ran by CMS in order to update that productivity adjustment, that would have yielded a positive adjustment to the market basket. And since the ACA multi-factor adjustment must be a reduction, that ended up becoming a zero across the board. So the only real update to the market basket was the market basket increase of 2.4%. Now there are some other penalties that could be applied to the market basket because of EHR and IQR. So the IQR would be a 25% reduction to the base market basket rate, or in this case, a 0.6 percentage point reduction. And the EHR would be a 75% reduction to the base market basket, or in this case, a 1.8 percentage point reduction. So if you had no penalty, you would get the full market basket increase. Just the IQR, you would get an increase of 1.8%. EHR only penalty would be a 0.6% increase, and if you had both the penalties because of IQR and EHR, you would have no increase due to market basket. And it should be mentioned that CAUSE can have their overall payments reduced by up to 1% due to not having meaningful use of the EHR. So just kind of looking at some of the numbers, how many hospitals were impacted by each of these, and the total amount of impact. There were 156 hospitals that received a penalty for solely meaningful use of the EHR. And this is an impact of about $34.4 million overall in the IPPS program. Those who were solely impacted by the IQR penalty, there were 41 hospitals and about an estimated impact of $1.5 million. And then 32 hospitals were impacted by both of the EHR and the IQR penalties, and that's another estimated impact of $1.9 million. So as you can see, overall, 93%, 93.01% of your hospitals had no penalty. About 4.76% had EHR penalty. IQR was about 1.25%, and both was just under 1% of total hospitals with those penalties. Next, we're going to talk about the ATRA coding adjustment and the MACRA payment that gives a 5% increase due to that MATRA rate. So we're currently in the fourth of 6 years of rate increases to offset the reduction set by ATRA that had ended in 2017. And that had actually reduced inpatient payments by about $11 billion. And as you can see, the MACRA add-on percentage is there to try to alleviate that reduction. But as you can see, there will end up being a little bit left over. The ATRA reduction will not be reduced entirely by the time that the MACRA is done. And for 2021, that 0.5% increase translates to about an increase of $505 million for payments for this year. So kind of bring it all together and to show you the kind of the bottom line for the year, the operating rate for inpatient increased from $5,796.93 in 2020 to $5,961.19 with basically as a net increase of 2.84% going from 2020 to 2021. And the capital rate, you can see, increased to $466.22 from 2020 to 2021, which is a 0.84% increase. The breakout that we have below that is showing all the different adjustments that went into that increase for operating rate. So the top is your 2.4%, which is your market basket, minus the zero increase because of the productivity adjustment. Then the MACRA retro coding adjustment that we just mentioned, it's a 0.5% increase. Then there's wage index budget neutrality adjustments, which ended up being a negative 0.1% decrease on that market basket. And then any other budget neutrality adjustments had an increase of about 0.03%, which gives us our net change to the operating at 2.84%. Next, we're going to go into the next few sections of slides are going to be a little bit more of the details of some of the measures put forth in the final rule. We're going to start with Medicare DSH payments. So since 2014, CMS has determined that there would be a traditional DSH pool, and that this year it's projected as $15.171 billion. So that traditional pool is split into basically two separate pools, 25% of which would be paid under the traditional DSH method, and 75% would be dedicated to a new, what would be called a new pool, which would end up being paid as uncompensated care. As you can see that there's different factors that go into that 75% of the new pool. Factor one, we'll get into some of the details. Factor one being the base funding. So for 2021, the base Factor one funding, again being 75% of that, about $15 billion, is $11.378 billion, which is a decrease from 2020 of about $1 billion or $1.1 billion. However, the Factor two is then another reduction on that, and some of you may have noticed that from the proposed rule to the final rule, that Factor two pool has actually increased, so it's actually been less of a reduction. That's due to CMS doing analysis that included projections of uninsured due to the COVID pandemic, and because of their findings, they actually increased the Factor two available pool. And then the Factor three is actually the uncompensated care cost distribution based on that Factor two pool. And that is going to be based on each hospital's percentage of uncompensated care that they have total based on audited 2017 cost report data, specifically the S10 line 30. And it should be mentioned that any hospitals that were audited for that cost report year are going to be excluded from any trimming methodology that CMS has in order to reduce aberrant payments and other oddities that they find within the data. Also, for going forward, so for fiscal year 2022 and onward, CMS will use the most recent single year of cost report data that has been audited for a significant number of hospitals that receive substantial uncompensated care payments in order to calculate that Factor three. So smaller hospitals that don't really contribute too much to the UCC pool, or that their costs don't contribute that much to the overall cost pool, may not be targeted as much in auditing because of the fact of CMS wanting to make sure that there's a significant number of hospitals that have substantial UCC payments audited. And then that, once audits are done for that cost report year, that would be the most recent year in future years. It should be noted that there have been major swings in payment amounts due to only using a single year of cost data, or cost report data. In previous years for Factor three, there have been different methodologies that use 3 years of data rather than just one, and this is the second year that we're using a single year of data with the 2017. So as you can see, 30% of hospitals swung by at least 25%, 12% by at least 50%, and 3% of hospitals had a swing of payments of over 100%. And just to give you some context, overall in the hospitals that we analyzed, there were 3,275 hospitals. So to give those percentages a little bit of context there. So going a little bit further into the Factor three determinations, CMS did finalize some new policies in terms of that. For hospitals that had mergers, when a merger occurs partway through the surviving hospital's cost report year, the data of the acquired hospital would not be annualized, and uncompensated care data would be reflective of care provided prior to the effective date of the merger, and that will be used. but it would be within the new parent's current cost reporting period. I know that was a mouthful, but that's basically what CMS wanted to do, is make sure that when two hospitals merge, that the data doesn't get double counted anywhere. So they finalized a few policies in order to reduce that. And then for hospitals that have cost reports starting in one fiscal year that span the entirety of the next, CMS finalized that they will annualize these cost reports where the data year used falls within the next fiscal year. So to continue on with some of the policies, for all-inclusive rate hospitals, these hospitals will remain excluded from the factor 3 calculation of statewide average CCRs in the trimming methodology due to how different their cost-to-charge ratios tend to be. CMS currently uses S10 data with trimming applied for these hospitals as the trimming mitigates aberrant cost-to-charge ratios. And CMS also finalized to instead adjust the trimming methodology for these hospitals for 2021. So for the trimming methodology, the 2017 line 30 values, if they're greater than 50% of these hospitals' operating costs, then CMS would recalculate that value using the cost-to-charge ratio from the most recent available cost report that would not also result in a line 30 value of over 50% of their operating costs. For new hospitals created on or after 2017, it was adopted by CMS that these hospitals would not receive interim uncompensated care payments, but instead they'd be paid these payments at cost report settlement. The factor 3 would be determined based on their individual fiscal year 2021 S10 as the numerator, with the national 2017 S10 value as the denominator. So new hospitals get a little bit of a break on their first year because of that. And for new hospitals created on or after October 1st, 2017, it was adopted by CMS that these hospitals would not receive interim uncompensated care payments, but instead they'd be paid these payments at cost report settlement. The factor 3 would be determined based on their individual fiscal year 2021 S10 as the numerator, with the national 2017 S10 value as the denominator. So new hospitals get a little bit of a break on their first year because of that. So for uncompensated care at discharge, CMS has adopted the use of a hospital's 3-year average discharges to estimate interim use. So for uncompensated care at discharge, CMS has adopted the use of a hospital's 3-year average discharges to estimate interim UCC payments per discharge. This would be, again, reconciled at cost report settlement as in past years. And to reduce the risk of overpayment, UCC payments per discharge. This would be, again, reconciled at cost report settlement as in past years. And to reduce the risk of overpayment, and to stabilize cash flows, CMS is also allowing hospitals to request that their MAC reduce their per discharge UCC payments. So this is so that if a hospital believes that their per discharge interim payments are a little bit higher than they feel they would be at year end, they can opt to take less money so that they wouldn't have to pay back CMS for any overpayment that they have. Hospitals had 15 business days from the date of the public display of the final rule to review and comment on the accuracy of the DISH data table that was sent out along with the and to stabilize cash flows. CMS is also allowing hospitals to request that their MAC reduce their per discharge UCC payments. So this is so that if a hospital believes that their per discharge interim payments are a little bit higher than they feel they would be at year end, they can opt to take less money so that they wouldn't have to pay back CMS for any overpayment that they have. Hospitals had 15 business days from the date of the public display of the final rule to review and comment on the accuracy of the DISH data table that was sent out along with the final rule. Any of these changes CMS stated would be posted to the website prior to 10/1/2020. Final rule. Any of these changes CMS stated would be posted to the website prior to 10/1/2020. So next we're going to go over some of the changes with the wage index, including the wage index calculation, CBSA changes, and other changes based on those. So for our wage index calculation, CMS utilized the calendar year 2019 occupational mix survey for use in the fiscal year 2022, and this was actually due to max by September 10th, 2020. The original deadline was July 1st, but CMS had granted extensions due to the COVID. So next we're going to go over some of the changes with the wage index, including the wage index calculation, CBSA changes, and other changes based on those. So for our wage index calculation, CMS utilized the calendar year 2019 occupational mix survey for use in the fiscal year 2022, and this was actually due to max by September 10th, 2020. The original deadline was July 1st, but CMS had granted extensions due to the COVID-19 pandemic. However, this occupational mix survey was the only opportunity to correct or revise data that hospitals may have recorded incorrectly, COVID-19 pandemic. However, this occupational mix survey was the only opportunity to correct or revise data that hospitals may have recorded incorrectly, that they submitted to CMS to change their wage index or to influence the change of their wage index for 2022, unless that data had been mishandled by a MAC. So if the data that you sent or that was sent in, that they submitted to CMS to change their wage index or to influence the change of their wage index for 2022, unless that data had been mishandled by a MAC. So if the data that you sent or that was sent in was incorrect, that was the only chance until the occupational mix survey for 2020 for 2023. Was incorrect, that was the only chance until the occupational mix survey for 2020 for 2023. Now going on to some CBSA changes for fiscal year 2021. As I mentioned before, the Office of Management and Budget, or the OMB, bulletin number 1804. Now going on to some CBSA changes for fiscal year 2021. As I mentioned before, the Office of Management and Budget, or the OMB, bulletin number 1804 that was released on September 15th, 2018, contained numerous changes to hospital wage areas. 4 that was released on September 15th, 2018, contained numerous changes to hospital wage areas, and these final CBSAs are still based on the 2010 census data. This bulletin was used in order to actually recalculate and restructure the CBSAs and wage indexes for the 2021 final rule. So CBSA changes result in new CBSAs, counties changing between urban status and rural status, as well as the division and change of existing CBSAs, including what counties are included in CBSAs, as well as the name of some CBSAs. So just as, so a couple of impacts of these CBSA changes. There were some counties that were some of the impacts due to that. CMS finalized that hospitals in these counties that became rural were to receive an add-on to their traditional DSH adjustment equal to 2/3 of the difference between their urban and rural calculated adjustments for 2021. Meaning that whatever adjustment they would have gotten as an urban county, or I should say, any provider that had been in an urban county that is now rural would receive 2/3 of their, what would have been their urban adjustment as a rural adjustment. This will be reduced to 1/3 of the difference for 2022 and phased out in 2023. On the flip side, counties that were rural and became urban, any critical access hospitals located in these counties would have 2 years to reclassify as rural in order to retain their cost status. And CMS did reevaluate their list of Lugar counties based on the 2006, to 2010 5-year American Community Survey. And one thing I want to mention is that in the CMS impact file that was included with the analysis that we gave you, there's actually an incorrect column in that table where any Section 401 hospitals that should have been reclassed as as rural, were actually given their urban labor markets as opposed to their new rural markets. And if you look, we accounted for that in the calculations to make sure that everything was accurate. So, to just give a summary of what counties were impacted between urban and rural, as you can see in the top left, we have the counties changing from urban to rural that have inpatient facilities. We weren't concerned about counties that changed from urban to rural that didn't have inpatient facilities because it wouldn't really impact anyone here. As you can see, most of them had one hospital in them, except for one in Louisiana that had 2 hospitals. So overall, 10 hospitals go from an urban county to a rural county. In the bottom right, you can see all of the hospitals that were, or all the counties that were impacted from going rural to urban. Again, that had inpatient facilities, and again, this is out of 47 counties. So as you can see, 15 hospitals in this case, 1 per county, would be impacted by this. left, it's 9 counties that were impacted and 10 hospitals that were impacted by this. It should also be noticed that no hospital that changes from to rural from urban would be affected by a DSH transition due to its county's Lugar status. They would still remain urban for DSH and capital purposes. Again, that's based on their Lugar status in that case, or the county's Lugar status, I should say. So going more into wage index reclassifications, hospitals reclassified into CBSAs that will be split apart will be assigned to the nearest county located both outside the hospital's 2021 geographic CBSA and within the original 2020 reclassified CBSA. So for county and group reclassifications, the nearest criteria would be based on the county nearest to the majority of the hospitals in the group. In order to be assigned to a different CBSA that would be containing at least one county from their fiscal year 2020 reclassified CBSA, as long as they meet the reclassification proximity criteria, which is about 15 miles, a hospital must have submitted documentation to CMS within 45 days of the proposed rules publication in the Federal Register. So that was published back in May, and that would have been due on July 13th. Just to give you a little bit of a history there. And hospital reclassifications that became part, or hospitals that reclassified that became part of the home CBSA will be assigned a home area reclassification and will receive the geographic hospital wage index. Further on with wage index reclassifications, wage data for MGCRB reclassifications, CMS will allow hospitals with fewer than 3 years of applicable wage data to seek MGCRB reclassification. With a few caveats, if only 1 year is available within the current window, then reclassification will be based on that year. If only 2 years are available, then it will be based on 2 years. However, hospitals without 1 year of data would be ineligible for that reclassification. Then CMS also finalized to allow hospitals to submit their MGCRB appeals electronically. Previously, it had to have gone through either non-electronic means, I should say. So next, we're going to look at the national impact due to standard wage index changes. And this does account for the change in wage data and CBSAs. However, it does not account for the bottom quartile impacts nor the 5% stop loss impacts. So this is strictly based on any wage data that hospitals provide, as well as the new delineations. As you can see, there are some areas that fare worse than others. The states in the Southwest, primarily those who may share CBSAs with California, had a little bit of an impact, as well as New Jersey, due to sharing CBSAs with New York City, saw some decrease as well. And Delaware and the Midwest also see some decreases. And it should be noted that the overall national impact due to the wage data and the CBA changes is about negative 1.9%. So overall, a decrease in the nation. So starting last year, CMS actually created about a 4-year system in order to try to increase employee compensation by increasing hospitals that have low wage indices. So for 2021, CMS is going to continue to increase the wage index for these hospitals that are below the national bottom quartile of the wage index. So for the final rule, that bottom quartile number is actually 0.8465, which is actually higher than the 2020 bottom quartile, meaning that more hospitals will actually benefit from this than potentially previous years, or the previous year, I should say. The new wage index that any provider that has lower than a 0.8465 wage index would receive would be the halfway point between their base wage index and that 25th percentile value. And again, this CMS said this will last for at least 4 years and is kind of a use it or lose it. It's meant to help increase the low hospital wages, to ideally increase wage index overall, but that this must be used for wages. So some hospitals may use it for other things, but ideally it's to help increase wages, to help increase that wage index so that your lower wage index hospitals can have a little bit higher of a wage index in the years to come. Continuing on with some information about wage index disparities, the budget neutrality offset of this rule was a finalized net adjustment of 0.09% to the operating rate, which was an overall increase of about $103 million to that operating rate. And this is actually an overall 0.12% reduction for fiscal year 2021, which is offset by the reduction of 0.21%, that was adopted in 2020. So even though the budget neutrality rate for 2021 is a reduction, we're still seeing a year-to-year increase because of the fact that the budget neutrality reduction in 2020 was so much higher than it would have been this year. And likewise, for the capital rate, the finalized net adjustment would be approximately a 0.17 increase to the capital rate, or about $14.3 million year-to-year 2020 to 2021, because of the fact that there was only a 0.06 reduction for fiscal year 2021 compared to the 0.23% reduction adopted for 2020. So this map actually shows the overall year-to-year impacts due to that budget neutrality offset. As you can see, most states actually ended up benefiting from this, and you can see that Arkansas was probably the sole loser in this case. So one of the big things in 2021 was because of the OMB delineations, CMS decided to do another 5% stop-loss adjustment. And again, this is for a transition period because of the new wage indices. So any hospital's wage index for 2021 was set to be no less than 95% of its final 2020 wage index. But that 2020 wage index could have also been part of a stop loss from 2019's wage index. So there is kind of a rolling effect for some providers here. And overall, applying these reductions, ended up having a 0.2% reduction in the operating rate and a 0.09% reduction in the capital rate, or negative $220 million overall reduction because of this. And I will note that the 5% stop loss on the wage index is because of any reduction of wage index, not just because of a redelineation. So as you can see, the 5% stop loss impact for 2021 hits each state pretty differently. The overall national impact is 0.08 or negative 0.08%. Some states faring better than others, mostly the states that were being hurt by the wage index changes, not due to the stop loss, seeing a little bit of the benefit. Bring everything together in terms of wage index changes, you actually see some overall, the states that were doing well did a little less well. Some of the states that were doing poorly did a little bit less poorly overall, typically by a 0.1 or 2% change. But in terms of all wage index changes, there is a national impact of negative 0.16%. So going on to some other changes set forth in graduate medical education, CMS is set forth funding tied to program closure, so that residents would have somewhere to go, or at least funding would find a way. So CMS allowed time for residents to find a new hospital and would or will link temporary GME funding to the day of public announcement of a closure of a residency program, rather than the day prior or the day that that residency program closes. And groups 2 and 3, so residents who are not at a hospital yet, funding will also be transferred for those groups of residents that are not physically present at the closing hospital, but have intended to train or return to training at the closing hospital's program. So for market basket DRG rates, for cost reports ending on or after January 1st, 2021, CMS adopted that hospitals be required to report the median payer-specific negotiated charge for Medicare Advantage payers by MSDRG. However, CMS did not finalize the requirement to hospitals to report all negotiated rates for third-party providers. So just to reiterate, CMS is requiring that starting January 1st, Medicare Advantage payer-specific negotiated rates must be reported. However, not all third-party provider negotiated rates must be reported. Hospitals receiving only non-negotiated payments, such as Indian and tribal hospitals and federally owned hospitals, CAS and hospitals in Maryland, would be exempt from this data collection. Going on to the Medicare bad debt policy, CMS adopted its clarification and codification of certain Medicare bad debt policies from the provider reimbursement manual that determines what types of bad debts are reimbursable under Medicare. These include the following: definitions of indigent and non-indigent beneficiaries. Reasonable collection efforts must involve the issuance of a bill, so a bill must be sent. 120 days must pass with no payment prior to writing off bad debt. If a patient pays back any of the amount within that 20 days, the 120-day count starts anew. Collection efforts must be similar for both Medicare and non-Medicare patients. So providers must have the same effort with collection efforts from Medicare beneficiaries as they would for any other payment. And any collection effort must be documented, and CMS did mention that they could be potentially auditing that documentation. So a couple of additional policy adoptions in this final rule. CAR T-cell therapy was given a finalized MS-DRG of 018. CMS finalized this year as opposed to last year, since there was now substantial enough data to make to properly finalize this DRG. And there's new hip and knee joint replacement DRGs, 521 to 522. These are taking some procedure codes from the current CJR DRGs. There were some changes to the post-acute transfer policy DRG list, primarily due to the CAR T-cell and hip knee DRG changes. The data used for Seoul Community Hospital applications was updated, and as was data used for the annualization of discharges for RRC eligibility. High ESRD discharge payments. CMS also adopted high ESRD discharge payment percent exclusions, as well as finalized that data submissions to IQOs would be required to be submitted electronically, and that any provider that has an issue with electronic submissions must get a waiver for fax or mail submissions. And either way, CMS did put forth reimbursement policies for each of these. Now I'm going to hand it off to Lauren, who will discuss all the quality program changes for 2021.
Thanks, Jacob. So there weren't too many changes for the quality program in the inpatient final rule. So you could just on the next slide, for the value-based purchasing program, there were no new measure additions or removals for the upcoming program years. CMS set the national performance standards for a subset of the measures that are in the federal fiscal year 2023, 2025, and 2026 programs. CMS will set the performance standards for the other measures in these program years in future rulemaking. And CMS noted that in the August 25th COVID-19 interim final rule that had a comment period that they released, they updated the extraordinary circumstances exception policy for the VBP program so that no claims or chart abstracted data from services between January 1st, 2020 and June 30th, 2020 will be used in calculations of the VBP program. And in the 2021 inpatient rule, CMS noted these in the charts of all the performance periods and baseline periods for the upcoming program years with an asterisk next to the ones that are impacted if you're looking to see what performance periods or baseline periods might have changed. And that's all there was for VBP in this rule. So next I'll talk about the readmission reduction program. In order to provide better certainty around future program performance periods, as well as streamlining the process and providing consistency throughout the years, CMS adopted an automatic adoption of performance periods that would begin federal fiscal year 2023 and continue for all subsequent program years, unless otherwise specified, like the COVID-19 situation. So the performance period will always be the 3-year period that begins 1 year forward from the previous program fiscal year start year, the performance period. So essentially it's a rolling performance period that moves forward 1 year for every program year, and it's always going to be a 3-year period. This is a 3-year period from which data is collected to calculate excess readmission ratios as well as payment adjustment factors for that year. And this will also be the same 3-year period for calculating full benefit dual eligible ratios and that sociodemographic status adjustment. So that will always correspond with that 3-year program performance period. And CMS notes that for 2023, the performance period is that 3-year period from July 1st through June 30th. CMS also notes for the readmission rule that based again on that August 15th COVID-19 rule, there'll be no claims in the readmission program that reflect services from January 1st, 2020 through June 30th, 2020. So the 2020 readmissions program will only use data from July 1st, 2017 through December 31st, 2019. CMS, consistent with their plans from the 2020 final rule, included data that's stratified by patient dual eligibility status for each of the 6 measures in the readmission reduction program and the confidential hospital-specific reports during the spring of 2020. This is in addition to what is currently on Hospital Compare, and they did this using 2 different methodologies. Within hospital disparity method, which looks at differences in outcomes for dual eligible patients versus the non-dual eligible patients within a hospital, and the dual eligible outcome method, which compares performance and care for dual eligible patients across all hospitals, not just within the hospital itself. So as I mentioned, this is in addition to what is currently in Hospital Compare. It's separate from the stratified methodology used in the program with the quintiles. So it's not used in any payment calculation for the readmission reduction program. And it's really just there as a point of reference and comparison for hospitals as they look at their data and try to see how they're doing with their readmissions. And that was all for readmissions in the 2021 inpatient rule. So now I'll talk about the hospital acquired condition program. CMS had a similar policy with the HAC program as they did with the readmission program, where they finalized the automatic adoption of performance periods, beginning again with that 2023 program and continuing for the future program years unless otherwise specified. So in this case, the program performance period will always be the 2-year period beginning 1 year advanced from the previous program's fiscal year start of the performance period. So this is similar to what I was talking about in the readmissions, where it's a kind of a rolling performance period that is always 2 years long and just moves 1 year forward for the start each time. And this again is just to provide greater certainty in the program and consistency as hospitals try to navigate it. Now also similarly in the HAC program, again, CMS won't be using any claims or chart-extracted data reflecting services provided between that January 1st and June 30th, 2020 dates. For the HAC program. In this case, some data reporting has been made optional as well. So I just noted here, if you're interested in exactly what pieces of this data is optional, you can refer back to that rule to find that out. And then finally, for the HAC program, there are a couple more details here that CMS updated. So there were several changes to the process for validating the HAC measure data. And this is really to reduce burden and streamline the process with some other adoptions that were also made for the I2R program measure validation process. So currently, the HAC validation uses 4 quarters of data. The 2023 program currently would have used 3rd quarter and 4th quarter 2020, and then also 1st quarter and 2nd quarter of 2021. To start aligning the program validation period, CMS wants to move to a calendar year. So therefore, for 2023 only, CMS will use data from just 2 quarters, the 3rd quarter and 4th quarter of 2020. Then starting with 2024 and moving forward, CMS will always use 1 calendar year of data. So for example, in 2024, that will be calendar year 2021. Currently, also for validation, CMS uses a pool for HAC of 600 hospitals, where 400 of those hospitals are randomly selected, and 200 are selected with a targeting criteria. CMS instead is reducing this pool in total for 400 hospitals, where it would be equal for those who are randomly selected, and those are using the criteria for selection, so 200 for each. This would be effective with the 2024 program. These would be the same hospitals that would be used in the IQR validation process as well, as long as obviously the measure data is available for RQR. So this would actually reduce the amount of hospitals that were validated by 1/3. That's a good thing. And then finally, currently hospitals have the option of submitting their medical records for validation by paper or through a secure electronic submission process. But now CMS is requiring hospitals to submit a PDF using a direct or electronic file submission through a CMS-approved secure file transmission process, rather than using some of these other options that you see here, like a CD or a DVD or a flash drive for those submissions. And CMS will continue to reimburse hospitals at $3 per chart that they submit. And that was all for the quality section of the inpatient rule. So I'll pass it back to Jacob to talk about the analysis.
Thank you, Laura. So I'm just going to do a quick walkthrough of what everyone will be seeing or has seen in the analysis. So first, this is for each hospital. We have a breakout of the overall impacts by operating and capital, flowing downwards from the 2020 estimated payments. And then all of your impacts here that are in white, if you add those together, should sum up to your 2021 payments. All of the indented and grayed out columns and values here are actually breakouts of each main column that you see here. So as you can see, we have all the impacts for your market basket, your ACA reduction, the MACRA adjustment. Then we have two wage index lines, the first one being for wage data and reclassification, similar to how we went over it before. And then the second one are all other changes. So that includes our stop loss, our bottom quartile wage index values, or I should say the 2020 stop loss expiration, the bottom quartile change, and the 2021 5% stop loss transition. The next will be any change in urban-rural status that a hospital has. That would also include any traditional DSH impacts due to moving from urban to rural. That was that 2/3 transition that we talked about earlier. And then our any DSH payments broken out as well as the distribution factor change. Below that, you can see any penalty that this provider would have due to not being part of, or due to not participating correctly in either the IQR or the EHR programs. Those are not built into the top here, but you can see below what the overall decrease due to those penalties would be. Also, you would see the 2% sequestration that's applied to all Medicare. However, due to the CARES Act, that was waived for the first 3 months of fiscal year 2021. So the impact that you have down here would include, or would not include the reduction for those 3 months. So as you go further down in the report when you get the analysis, you will see a breakout of your UCC payments. The top part of this particular window shows the national pools for 2020 and 2021, as well as the overall change year to year. And the bottom is the hospital-specific factors. So it shows 2020's payment factor, as well as the amount that the hospital will be paid in 2020 to 2021, as well as the net change, whether it be positive or negative for both the factor and the UCC amount. Below that UCC payment change is a breakout of the quality changes that we estimate. So these are year-over-year factor and payment changes. The VBP and the HAC changes are based on DataGen estimates, which are based on the second quarter 2020 hospital compare. The readmissions adjustments are based on CMS's estimates overall. So those will all be typically what providers will see in the hospital report that we provide. The next slide will show the other tab or the other information that we provide typically to hospitals. This is just a breakdown of the calculations to get to the overall impacts based on the federal operating rate. So here you'll see the base operating rate, what labor share the hospital would get based on their wage index, any wage index changes. As you go down, you see how each of the different impacts to the overall payment changes from 2020 to 2021, as well as the percentage and other hospital-specific information. Below this would be details for the capital rate, as well as detailed impacts on wage index changes. So I know I just unload a lot on anyone, but if there's any questions, please put them into the Q&A or the chat, and we will answer anything that you have.
Thank you, Jacob and Lauren. That's a great overview. There was a lot of information in that final rule that was presented today. The PDF of today's slides and the recording will be shared with you tomorrow. I did have one question on the readmissions adjustment factor. We recognize that CMS has since published the final 2021 readjustment factor, and that is not embedded in this inpatient final rule analysis, so that might have caused a little bit of confusion. We still have a minute here if there are other questions. Feel free to reach out through your state association or system, and we can answer any questions that they may want to forward our way. We appreciate your time and have a wonderful afternoon. Thank you very much.